Okay, we're going to start with Dr. Abraham. Look at him. Which camera is he in? One? Okay, he's in one. Okay, stand by for a countdown.
So I'm
Here we go
starting.
in 5, 4, 3, 2, 1.
Hi, I'm Dr. Jame Abraham. Welcome to the Cleveland Clinic Tumor Board series. Today's topic is hormone receptor-positive advanced breast cancer, challenges and new treatment options. We'll use a case-based interactive approach to discuss new treatment options for patients with hormone receptor-positive breast cancer. I'm joined by Dr. Finn, Dr. Richard Finn, who's an associate professor at UCLA, and Dr. Dickler, interim chief of breast medicine, Memorial Sloan Kettering, Dr. Budd, professor of medicine, Cleveland Clinic, Dr. Horabaji, professor of medicine, MD Anderson Cancer Center, Houston. So we're going to start with our first patient. So again, it's a 54-year-old patient with a history of stage 2A, T1N1, ER, PR positive, HER2 negative breast cancer, diagnosed about 8 years back in 2009. And originally she was treated with 4 cycles of TC, and then she was premenopausal. She was put on tamoxifen until 2014. So let me pause here. She had 4 cycles of TC. So what's your thought about TC versus anthracycline in this setting? She was young and a node-positive disease.
Sure. I think clearly the most important thing in the management of this lady's cancer is going to be the endocrine component, right? The biology of this tumor and the long natural history and the good outcomes is dictated mostly by the endocrine treatment. So then, if we step back and say, what is the role of chemotherapy for this lady? Certainly with node-positive disease, she's young, premenopausal, we would look and say that there probably is some marginal benefit from chemotherapy, and then it becomes what's the chemotherapy regimen. And looking at the data, it's hard to say convincingly that there's a beyond the doubt benefit in the absence of HER2 amplification, that there's a benefit for anthracyclines in this type of patient. Studies have shown that's a very small incremental benefit if there is one, and then also in the context of other studies which show that even non-inferiority or even no benefit with anthracycline. So I think this would be a very appropriate regimen for her.
Dr. Dickler, is that?
Yeah, well, I think recently data was reported to address this. The ABC trial was recently published by Blum and colleagues that suggested that anthracyclines do have a role. And in that trial, it was a number of anthracycline-containing regimens versus TC. And in that study, it was TC times 6. And anthracyclines were superior in a statistically significant manner, although the differences are small and are more notable in the ER-negative population, so obviously not this patient. But really, meta-analysis from the early breast cancer clinical trialist collaborative group has suggested anthracyclines show benefit, and now I think the ABC trial is a large randomized conglomeration of studies that also supports that. I think it's also important to look at the anthracycline-containing regimen. I think dose-dense regimens tend to be better than every 3-week regimens, so I don't think necessarily TC is inferior to Q3 anthracyclines, but when given dose dense, I think there are benefits.
Okay. Dr. Budd, what's your take on it?
Well, I would say I would generally use TC in this type of patient. I mean, I think we have 3 trials, not all published. There was ABC trial that was mentioned, this German trial that indicated non-inferiority, and for ER, largely ER-positive patients. A recently published trial looking at patients who had non-amplification of topo-2 alpha, so that kind of gets at the biology a little bit more. So that I think the efficacy in this type of patient would be similar, and if there's a difference, it may be in the range of magnitude of chronic toxicity. So you're kind of, making that calculation.
Right. Dr. Horabaji at MD Anderson, what do you do?
So I tend to agree with Richard that the most important part of the systemic therapy of this patient is going to be endocrine treatment. And the more fundamental question in this situation is whether she needs chemotherapy at all. And of course, since 2009, the world has changed. And what we would do in this case today would be to use one of the genomic assays, although we are still waiting for the results of the definitive trials, in this case the responder trials from SWOG. But the question is, does she have a high enough risk, and does she belong in the category where chemotherapy would be of benefit? If so, then the advantage tends to be larger than if you dilute it by thinking of all ER-positive, node-positive breast cancers. If she is likely to benefit from chemotherapy, my group in general tends to use an anthracycline-based regimen. In 2009, I think for low-risk patients, some of my colleagues would have used TC. Most of my colleagues in the institution would have used an anthracycline-based regimen. I think we are awaiting with great interest the results of both the TAILOR-X and the responder trial, because I think we can spare the side effects and costs of chemotherapy to about 50% of our patients.
So it should be a risk-based approach
That's
in
correct.
selecting the agent. So she was on tamoxifen. She did well till 2014 or so. Then she presented with back pain, and then she had extensive workup, including a PET scan, which showed multiple lesions in the bone and liver. And otherwise she was completely asymptomatic. So she had a biopsy, and the biopsy confirmed that it's adenocarcinoma. It's consistent with breast primary, strongly positive, PR 10%, and HER2 negative. So and I'm sure now in this day and age we recommend biopsy for all metastatic, so I think it's uniformly accepted. Is there any concern of bone biopsy versus liver, or do you go after one versus the other? Or
I think markers are obviously going to be easier on a liver biopsy, and it's safe, and generally if it's easily accessible, that would be where to go.
Right. So she has markers done, 90%, PR 10%, and HER2 negative. And again, she's fairly asymptomatic other than the back pain, and she's in your clinic, and she's saying, I want the most aggressive treatment, and which has the best survival. So I'm going to put some options, and then probably we can talk about different things. And one of the first questions we have, again, with our traditional teaching, the patient has visceral disease, and she has some symptoms. So what's the role of chemo? And I think I put paclitaxel, but let's just talk about chemo in general. So probably I'll start there with Dr. Harbaji.
So I think we learned a very valuable lesson about 25 years ago, that more aggressive doesn't necessarily mean more effective. And I think in this particular lady's case, the example is perfect, because for her, I think the treatment of choice would be endocrine therapy, modern endocrine therapy. And while chemotherapy will be used at some point in time in her clinical course, I think patients with hormone receptor-positive breast cancer, unless they are in a frank visceral crisis, should be started on endocrine therapy. That would be my choice.
So how do you define visceral crisis? What's your take on how do you say it's visceral crisis?
You know, I think the real question is, do we have time for them to wait to respond to endocrine therapy, right? Okay. Endocrine therapy responses aren't as fast as with chemotherapy, with cytotoxics. And if we look at time to response maybe being 2 to 3 months, if someone, will fall off a cliff, so to speak, go into liver failure, respiratory failure, then maybe you need to start with chemo and get things under control, and then you can always revert back. This term visceral crisis is used a lot, and to your point, obviously, objectively, if someone has Their beeper going off, I guess.
That's my beeper, yeah. Let's just take that out. That's the beeper. Right, sorry. We can pause. We can.
At least it was on stun.
We can pause. And,
That was too good. I couldn't resist.
Yeah, oh, now we get
yeah.
These are the bloopers.
I know.
It's funny, I have a beeper too.
Outtake
and
reel.
no one uses beepers anymore. I love my beeper.
Yeah.
You got, excuse me, he got some orange stuff on his jacket. I mean, there you go.
I think clinic uses beeper. You know.
Oh, yikes.
Sorry. So I'll start again with some crisis.
Okay, well, okay.
All right. So
I got to get my composure.
You had a request for me, what was it again? Bite shot. Stand by and ask the question again and anytime.
Yeah, everyone pull your jackets. Yeah,
Oh,
thank you.
Can you just answer the question, then we'll go from there?
okay.
Dr. Finn? Okay.
Well, let him ask. Can you ask the question?
Yeah,
Okay. Okay. So how do we define visceral crisis?
I think the real question with this issue of visceral crisis is, do they have time to respond to an endocrine manipulation? Certainly, again, the most important management for this patient will be endocrine therapy, but it takes time to work. For a patient who has bulky visceral disease, elevated liver enzymes, respiratory problems where they need a quick response, then cytotoxics would be an appropriate option. And then you can always go back to endocrine treatment once things cool down a little bit. So I think the real question is, do they have time to wait for endocrine treatment?
So that's a critical point, right? And, I mean, any visceral disease, we've been kind of leaning more towards using chemotherapy, and now we are really shifting to an endocrine approach. So in this patient, she's overall asymptomatic with normal LFTs. You're comfortable in saying we can think about endocrine treatment, or, as you said, some effective modern endocrine treatment.
So this lady has a cancer history of about 9 years now,
Right.
or 8.
Right.
And she's been disease-free without treatment for 3 years.
Right.
So her disease is not galloping.
Right.
I think it provides us with a fair degree of comfort that we can let endocrine therapy work. Now, having said that, I've often thought about whether it is true that the speed of response is different between endocrine therapy and chemotherapy. Because in some patients who are symptomatic, especially I'm thinking of patients with bone metastasis who are symptomatic, sometimes you get a symptomatic response within days with endocrine therapy. Now, it might be that we cannot document an objective response as fast with endocrine therapy in general as with chemotherapy in general. But I think many patients who receive endocrine therapy respond much faster than we think. But I think the overall difficulty is to really find that level of comfort in the absence of definitive data about this possible controversy of whether the patient will or will not wait, and will we have a second chance for treating her. In this case, I think I'm perfectly comfortable because of her disease-free interval, the relative paucity of symptoms, and we didn't hear about the extent of disease, but from what you told us, reading between the lines, I did not get the impression that she had massive metastatic disease.
Right. So if we have to choose a chemo, do you have any preference, taxane versus capecitabine or any?
Yeah, I tend to. I mean, weekly paclitaxel does cause hair loss. It is relatively slow. It's not like dose dense in the adjuvant setting where you lose it in 2 weeks, but still women generally who are going to live many years with their metastatic disease very much care about alopecia. So I tend to use capecitabine in this setting. I feel it's very effective, particularly in ER-positive patients. I think that it's an oral option, so it requires less visits to the clinic, really allows women to continue to work and travel and maintain a good quality of life. So typically, for me, first-line treatment in a patient such as this would be capecitabine when I'm ready to use chemotherapy.
Okay. And Dr. Bird, do you agree?
Well, I would say yes. In those cases who kind of go through endocrine agents and then you start chemotherapy, I would agree that capecitabine would be the best approach. You may not have to worry about IV access. It's oral. They can get checks, their blood counts checked locally. They keep their hair. So it has a lot of advantages, sort of a starter chemotherapy. Now, if this were someone in visceral crisis, I might be inclined to use combination chemotherapy and might use an anthracycline in this case,
Right.
if that were visceral crisis.
Right. Because she never had anthracycline before, and right. Okay, so then the other choices are an AI and palbociclib. So Dr. Finn, you did all these studies.
Yeah, I think, again, not the audience needs to be very clear that the most important regimen, even for patients with visceral disease, is going to be an endocrine-based regimen outside of an extreme case where they're very ill. This lady has an incurable illness. The goal will be to make it as chronic as possible, as manageable as possible. And you say she wants what is going to improve survival, right? And that's been a hard thing to do, to actually show that we're improving OS in randomized studies. But the sense is that in ER-positive disease, survival is getting better because we have more options that are effective, and typically sequential use of these agents will maximize her survival. The data that's evolved in the past several years with CDK4/6 inhibitors has, I think, dramatically changed the landscape. Certainly in the frontline setting, we've seen consistently, whether it's with AI with palbo or AI with ribociclib, a 10-month roughly improvement in PFS, which is associated with some increase in toxicities, but generally I think we say they are manageable, mostly laboratory-based, and those are the leukopenia and neutropenia. And I think you'd have to come up with a pretty convincing reason why not to offer her a doublet AI plus CDK in this setting. Certainly we've seen recent data with fulvestrant versus anastrozole, the Falcon study, which the two seem fairly similar for PFS, 3-month benefit for fulvestrant, but even with fulvestrant in those patients who don't have visceral disease came out to be about 22 months. That's still inferior to and again, it's cross-trial comparisons, et cetera, but still inferior to the degree of benefit we're seeing with AIs and CDK, which is a PFS in the front line over 2 years. And that's a significant improvement. And in this case, I would see no reason not to do that.
Right. So, Dr. Harabaj, let's talk about ribociclib in this setting. So that's one of the new member in this. So how do we fit this?
Yeah, so we have 2 CDK4/6 inhibitors that have been approved by the FDA, and the third one that is rapidly heading in the same direction. And I think the results we have seen with these agents have been very impressive. And while it is true that it has been hard to demonstrate in individual clinical trials a survival benefit, the reality is that patients with metastatic breast cancer in general, perhaps with the exception of those with triple-negative disease, are living longer. And they are living significantly longer today than 20 years ago. And I think that is the accretion of small steps forward. And I suspect with the CDK4/6 inhibitors, that next step is going to be even larger. So I've been impressed by the results of the Paloma-2 and the Mona Lisa-2 trials for the reasons that Dr. Finn already mentioned. I find it hard to differentiate the 2 agents. Their therapeutic activity seems to be very similar. Their safety profile seems to be very similar. And while we have a long list of potential side effects, those are mostly asymptomatic to the patient. And the few symptomatic side effects can be well managed. So at this point, since both of them are commercially available, I find myself using both of them in day-to-day practice. And what I see in these two studies and the other supportive studies is that their efficacy seems to be more reproducible than what we see with fulvestrant alone. And especially in this patient who had visceral disease, the subset analysis that the Falcon trial has publicized, which suggested in one subset similar, perhaps prolongation of PFS, did not apply to patients with visceral metastasis, which is not true in the subset analysis of either the Paloma or the Mona Lisa trials. So I'm comfortable with both options 2 and 3 in this setting. I think those would be my first choices. We are waiting for the phase 3 of Monarch in frontline to determine whether abemaciclib will join the club in frontline therapy to the same level of comfort.
Yeah, I think the other thing to keep in mind, excuse me, is that the response rate with CDK and AI, whether it's palbo or ribo, is very high. I mean, it's 50% plus or minus. Clinical benefit rate over 80%.
Right.
I mean, there's no cytotoxic regimen, I think, that will give you that type of activity, and it speaks to, I think, the fundamental importance of this target.
Right. So you're saying there is no major difference between these two agents, and it's kind of it's tough to pick one versus the other, and I don't know how practitioners can.
So at this point, we have relatively limited information. We have treated a few hundred patients with these agents. And on the surface, we have not seen a substantial or clinically relevant difference. I suspect that as additional trials are reported, and especially as the adjuvant trials involve thousands of patients, we will start to see some emerging differences, or maybe not. We developed 3 aromatase inhibitors 25 years ago, and we still have to figure out whether one is better than another. And so far, the differences are not emerging. So it might be the same thing with these agents, or it might be that we will indeed see some differences that are clinically relevant.
Right. Dr. Dickler, I know you've been involved with Monarch 1 and 2. So how do you, that choice number 5, that's probably not relevant in this patient, right?
Well, she would have been eligible for the Monarch 2 study. So.
Okay.
It is an option. Abemaciclib is not yet FDA approved,
Right.
But the Monarch 2 data presented by George Sledge at ASCO did show, similar to the other drugs, that abemaciclib improves progression-free survival when added to, in this case, fulvestrant, with a pretty significant response rate and clinical benefit rate as well. So, once abemaciclib, if it gets approved, and we do suspect it will, it would be an option in this patient. I think the question as to whether we use AIs versus fulvestrant, which is a SERD, in the first-line setting, is still unclear. I think the interesting thing about the Falcon trial, although all patients were de novo and never had previous endocrine therapy, was that giving a SERD that degrades the estrogen receptor was better than giving an AI. So how these drugs kind of fall out will, I think, almost be which partner we use first in terms of the endocrine therapy. And I think as we learn more about underlying mechanisms of resistance, we may get a better sense of which drug we should use first. But I agree with my colleagues. I tend to use AIs as my go-to drug for first-line treatment in ER-positive metastatic breast cancer.
So Monarch 2, so this patient had tamoxifen and then had a gap of 2.
Right.
So that's an inclusion criteria for Monarch 2.
Yeah, Monarch 2, I would have to look again really closely, but yeah, it was actually quite broad.
Okay.
It really didn't require a non-steroidal AI. It just required progression on endocrine therapy. And so there are some overlaps.
Right.
I'm not so sure this is so clinically relevant,
Right.
But I think that she would have been eligible for that trial.
She would have been. So, Dr. Bud, in which patient you will use, let's just say, 2 things. One, single agent AI, or the combination fulvestrant AI. And is there any scenario you use that now?
Okay. Well, in this kind of situation, the question there's a group of patients who would do just as well with single agent AI. There may be, but we don't know who they are. I don't think we have a means to identify them as yet. So that's the problem we're faced with. I mean, maybe these patients with very long disease-free interval, or in the second-line setting, someone who had a long progression-free survival on first-line treatment would do just as well with single agent endocrine treatment. We all have patients who do extraordinarily well for a decade or more on single agent endocrine treatment, but right now I just don't think we have a mechanism or a means to identify them. I think it's an important question and something that we ought to get at for cost containment, for quality of life for the patient. But right now I don't think we have a means to identify those patients. In terms of using the combination of fulvestrant and anastrozole in the based on the SWOG trial, which used randomizing patients to anastrozole versus anastrozole plus fulvestrant, but fulvestrant at the lower dose of 250 milligrams IM after a loading course, then 250 milligrams IM monthly, there seemed to be an advantage in those previously untreated patients with the combination. So kind of maybe there is something different about those patients treated with fulvestrant. It's an interesting question. And there was a survival advantage for that group of patients in that study. But right now, I would say with these aromatase inhibitors in combination with a CDK4/6 inhibitor, I think that would be standard of care. But I do think it would be an important question to see what is the optimal endocrine partner.
And you know, it's impressive to me that the best results we get with a single aromatase inhibitor, it's about 14, 15 months in the most modern trials. The best result we get with fulvestrant is somewhere along that too. The study that Tom just mentioned, combining an AI with the lower dose of fulvestrant, the combination arm in that subset of patients got about 14, 15 months of PFS. And I think most of our patients would prefer a single, uninterrupted period of no progression or response to therapy with a well-tolerated regimen. So for the time being, and until we find biomarkers that allow us to select the appropriate patients for less therapy, I think we should choose the most effective therapy under most circumstances. And in this situation, that's the combination of an AI and one of the CDK4/6 inhibitors. And maybe fulvestrant with abemaclib once the entirety of the data becomes available, as well as the FDA approval.
Can I ask you all who are involved in these frontline trials where we are in identifying patients who might be treated with single agent treatment? Are there clinical or biologic factors being looked at?
Yeah. So there's two questions, right? I mean, who are the ultimate ones that get a benefit from dual therapy, and who are the ones who do very well with endocrine agents alone? You know, on all the curves from Paloma 1 to Mona Lisa 2, even in Monarch 2, there's always that group of patients that drops off very quickly within the first assessment. It's probably about 20-25% of patients who are endocrine resistant, and they are salvaged with the use of a CDK inhibitor. And who are they? You know, we have not identified yet, and even before the CDK space, no one has identified any biomarker of who those patients are, or on the other side of the curve, who does better. We do have an intense effort within the Paloma 2 study to identify those patients. Tissue was required at entry into the study, and we have an ongoing effort there. From what we've done by immunohistochemistry, we have not been able to identify this group of patients. There seems to be a consistent benefit, even for the ones who do well out many months, right. Out years, there's still a benefit to CDK inhibition. And as we showed at ASCO, from Paloma 1, which is the longest follow-up available, we have patients out six years on dual therapy, right? And there's also a few on the letrozole arm alone, but still, there's more on the combination arm. So it's something that we need to try to figure out, but as of now, we don't have the answer.
And if I could speak to this, with the help of my colleagues, I'm joining forces with a biostatistician and my European colleagues, Miguel Martin in particular from GAIACAM, to look at all of the first-line randomized trials that have a single-agent control arm of an AI. And we're going to try and look to see who are those patients who receive single-agent AIs, who are on the tail of the curve. And we hope that with the power of a meta-analysis, and not just several hundred patients, but maybe as many as 2,000 patients, we can better understand the disease and patient characteristics that identify that group on the tail of the curve. However, we've all seen the forest plots of these randomized studies with CDK4/6 inhibitors, and it's pretty clear that we have not yet been able to identify a subgroup that doesn't derive benefit.
In the Mona Lisa 2 trial, we have also had a very extensive effort trying to identify biomarkers of both success and failure. And so far, we don't have much to show for it. Now the effort continues, and we are just starting, the 3rd and 4th generation of assays trying to identify biomarkers, but it has been harder than initially thought. And we have the experience with the Bolero 2 trial and some of the other previous trials with endocrine therapy. It is not as easy to identify biomarkers of success. And many of our initial hypotheses have been defeated by ugly facts.
I mean, the initial hypotheses, and I have to come back to this, right? Because everybody's been asking for a biomarker. The biomarker from the beginning was ER, right? That was why these studies were launched. And it's the biology of ER and the other proteins that are involved in endocrine resistance that are probably firing in on the common cyclin D1 CDK pathway. And I think people might, to your point, have to just accept the fact that ER might be the best we can do. It might be worth identifying resistance markers, right? Because if the clinical benefit rate is 80%, we might not be able to say who does better, but maybe there is a group that do not get a benefit and maybe spare them the doublet.
Or move to chemotherapy, right? So there
I mean,
might
they
be a
still-
group
yeah.
of patients, yeah.
Or they might still get a benefit from endocrine therapy, just not the additional benefit of a CDK inhibitor.
So in the absence of a biomarker, and we don't know whom to select for that, in general, the recommendation is to consider a combination of an endocrine plus a CDK4/6 at this point in general, right? Okay, good. So we'll just take a break of 2 minutes, and I think
I'm
we'll
sorry, but we need to get back to you because your initial email came out during ASCO,
Don't worry, but
and then
know
you sent
what?
out another email.
Pfizer is helping us.
Okay.
So I sent it to you sort of as a FYI.
Yeah.
Maria Kohler's on the case. Gabe, it's the Novartis folks.
So
They are silent. I know you've been very helpful on the other trial, but now
no,
you're...
so I sent you a conditional
Yeah.
positive, and since then I have heard back from them that they are in principle very interested, and they are just getting all the mother may I from inside
Great.
the
I'll-
So
company.
see if
maybe
we
you
get
can
a little
bring
bit of
my
work
coffee.
done here too. So I'm pushing on my end, like I know the Novartis folks, but it's amazing what a positive response I've gotten. But
I do, some water would be
Yeah.
great.
It's the timing.
Sure.
It was
Yes,
just, you said the first one came out, and then there was a follow-up, and I was still...
so for your trials, I'm so good. I just sort of
Okay.
wanted to
yeah, no,
share
no,
with you.
I'll take a
and-
look. Because the second one had a lot more information.
No, so we're very far with Pfizer.
Okay.
Pfizer's already reviewed the data sharing agreement.
okay.
You don't need to do anything. It's
Okay.
great. The only company that and some of these trials, it turns out, are placebo-controlled and they're still blind. Are we allowed to keep our waters here?
It'd be a jump in the video.
Product
and all of a sudden
placement.
you're-
Okay, I spilled some too. I always squeeze these bottles.
Yeah.
Hang on, I'll gather.
Yeah. Or just put them by our legs. Just put them by our feet.
You have more vodka, just during the break. Everybody thinks it's coffee.
Okay, great,
I don't
thank
think
you.
I can reach.
Yeah, I'm so sorry.
Okay.
Yeah, and if you
there's no space.
we're messy.
Yeah.
Here you go.
Well,
Bartender.
it was over.
That was Jim Beam.
Oh, sure, sorry.
If you don't mind just putting it right down by my chair and then I'll know. Thank you so much.
We all have the same color lipstick now.
All right, we'll make sure.
Yes.
Is the sound okay? Any suggestions? Anything that's not working?
Craig thinks you can hear us well. And
Oh, you guys are great.
Okay.
The only thing, just try not to be too shifty on it.
Okay.
you're confusing. We're confusing you, but that's the whole purpose.
Yeah, I know. No, I think it's going real well.
Okay. And she's on treatment. She's on letrozole. This patient is on letrozole, and then she's found to have metastatic disease.
Okay.
So then I put letrozole palbo, everolimus exemestane, fulvestrant,
Give you those from a Craig.
fulvestrant, and
Tissue,
right.
Yes.
I don't know if she will meet Monarch. Probably she won't. She may meet the criteria.
Yeah, she
She'll
was.
meet the criteria.
I think the minority had TAM only. I think.
Majority.
Yeah, majority
Why-
would have fallen into this one.
Right, but she will meet the Paloma 3. Right. Okay.
Yeah, and I haven't actually mentioned the single agent activity, so maybe I'll slip that in for something different. You know, it's.
Yes, sir.
Right. Okay.
All right.
All right. Okay.
Bye.
All right.
Dr. Abraham on channel 1, case 2 in 5, 4, 3, 2, 1.
So let's move on to the second patient. She's a 64-year-old patient. She was diagnosed with a stage 2A, that is a T2N0, about 4 years back. And the pathology was infiltrating ductal cancer, ER/PR positive, and HER2 negative. And she had an oncotype testing done, low recurrence score, and she completed her, she had her lumpectomy, radiation treatment, and then she was started on letrozole, 2.5 milligram. And she was fairly compliant with the endocrine treatment. And the compliance is an issue, right? I know we deal with that a lot. And so she was fairly compliant with the treatment, but she had some joint pain. But while on letrozole, she had some upper respiratory infection. She got a chest X-ray from her primary care doctor, and eventually she was diagnosed with metastatic lesions in her lung. And ER/PR was strongly positive and HER2 negative. So in this patient, she's overall asymptomatic from the metastatic lesions. It was kind of an incidental finding in her chest X-ray. What are the treatment options? So I will kind of start from the top. Letrozole palbo in this patient.
You know, the Paloma 2 study, the definitive phase 3 study, did not allow patients who relapsed on prior AI. That was the same for the ribociclib study. Paloma 2 and Mona Lisa 2 did differ a little bit in that Paloma 2 did have patients who relapsed less than 12 months on adjuvant therapy, about 20% of them, but that would have been tamoxifen or just chemotherapy. Whereas I think Mona Lisa 2 did not have any of those patients. But needless to say, this patient is progressing on a non-steroidal AI, and there's no strong data to support adding a CDK inhibitor there would change that outcome.
Right. So that's the first one is not an option for that patient based upon the data. What about everolimus and exemestane? Will you consider everolimus for a patient like this?
I do use everolimus in the treatment of patients with metastatic disease, but at the present time, I always use it after a patient has been treated with a CDK4/6 inhibitor. So I think that everolimus, the PFS benefit is much less than that when you add a CDK4/6 inhibitor to fulvestrant, which would really be typically what I would use in this setting. So that would really be my third line of treatment.
So, okay. So endocrine, fulvestrant, CDK, if they progress on that, then you'll go for
Yes.
right.
And I'm really interested in giving a SERD in this setting. So there are a number of SERD backbones, but I would rather switch it up from giving an AI, which lowers estrogen to undetectable levels, to a drug now that may degrade the estrogen receptor. I think it's important we're learning a little bit more about mechanisms of resistance and the development of ESR1 mutations, or mutations in the estrogen receptor gene. And ESR1 mutant tumors may have signaling down the ER pathway despite low circulating estradiol levels. So I'd rather give a drug in this setting that degrades the estrogen receptor.
So this patient would have been eligible for the Bolero-2, but even if the results of PFS were to be similar, the safety profile of the CDK4/6 inhibitors is more favorable than that of everolimus and exemestane. So even on that basis alone, I would prefer a CDK4/6 combination.
Will you consider fulvestrant by itself, or
Well, I think
fulvestrant with the
it's the same issue as,
Right.
we do have evidence that adding a CDK4/6 inhibitor would improve the outcome, and we don't have a biomarker or clinical marker for resistance or sensitivity, so I would use a CDK4/6 inhibitor, and I would use fulvestrant, I think. Looking at leaving aside the second drug, exemestane is, after a non-steroidal AI, is associated with a pretty short median progression-free survival in the order of 2.5, 3 months. Some of that is due to the ESR1 mutations that Dr. Dickler mentioned. So I would switch to a fulvestrant, and the partner would be palbociclib at this point. Although, I guess abemaciclib, when that comes along, would be an option.
Right. So that's so Monarch 2. She meets the criteria for Monarch 2.
Correct.
Right.
Right.
Okay. Out of this thing, can you tell us a little more about abemaciclib, or the dosing and?
Yeah. So abemaciclib can be dosed continuously without a need for a break, and that's because there's a little bit less myelosuppression with this agent. However, there is more diarrhea, so it's a slightly different toxicity profile. And I think the reasoning for that is it's thought that abemaciclib has more potent CDK4 inhibition than CDK6, and therefore there may be a less myelosuppression in that setting. However, the diarrhea in Monarch 2 was grade 3 in about 13% of patients, so it's really quite significant. The diarrhea is manageable, but you really need to communicate pretty clearly to patients that when they get diarrhea, that particularly grade 2 and 3 diarrhea, that they need to hold the drug. It's very responsive to a hold, and then instituting either Imodium or loperamide. And the diarrhea also, interestingly, is really seen in generally the first 1 to 2 weeks of use of the drug. Generally, if patients get through the first cycle without diarrhea, they're typically not going to develop it.
So you hold the drug, you don't cut down. It's 150 milligram daily.
Right, so initially Monarch 2 started at 200 milligrams twice a day, but after about a quarter of patients were enrolled, they decided to reduce the dose across the whole trial, and it's now 150 milligrams twice a day, continuous dosing. And the continuous dosing may also be important. It might be that continuous inhibition of CDK4 and CDK6 may be better than the intermittent dosing that's needed for palbociclib and ribociclib.
Right.
And maybe continuous inhibition of the target may be important.
I mean, that's been talked about, but so
Right.
far the clinical data is all the same. And I think at
Correct.
the end of the day, we're going to have 3 CDK4/6 inhibitors that all have very similar clinical activity, and the issues are side effect profile, which differ among all 3 of them, right? The package inserts right now for ribociclib and palbociclib are different in regards to monitoring. And then abemaciclib, you talked about the GI toxicity. At the end of the day, we'll have 3 drugs, and their use will be dictated, I think, by things other than clinical efficacy, because I think it's going to be pretty similar.
It's really interesting, as you were saying, 10 years back when we had these 3 aromatase inhibitors, we all were splitting hair and trying to find out which is better.
So there is ongoing work, at least with ribo, looking at the continuous administration at the lower dose. There's The only reason I think we ended up with 3 weeks on and 1 week off was because of toxicity and because of the insistence of using the maximally tolerated dose. But that doesn't necessarily have to be that way. And I think we need to do our homework and and test different dose schedules with these agents to figure out what is optimal. You can give ribociclib continuously, but you have to reduce the dose, which might actually be more favorable because the toxicity profile also changes, and some of the side effects seen at the 600 milligrams per day are not seen below at 400 and lower doses. So I don't think this is this experience is complete as yet, and we need to continue working with these agents until we find the sweet spot.
So you dose reduce for neutropenia, or what's in ribociclib? What?
So the general management of neutropenia, of severe fatigue, of QT prolongation, and liver function abnormalities is to interrupt, wait until you return to baseline for that particular symptom, and then reinduce. Often we can reinduce with the same dose and not have a repeat emergence of the side effect in question. And if there is a reincidence, then we again interrupt, wait until return to baseline, and then reduce one dose level, which for ribo is going from 600 to 400.
So even with the prolonged QT interval, we can still drop the dose and continue now.
Oh, absolutely.
So it's not like an absolute contraindication.
No. And you know, the QT prolongation is a laboratory phenomenon. We have not seen any clinically relevant consequences of the QT prolongation. The only importance is, of course, to exclude at baseline those who have a QT of greater than 450, and that way you eliminate a very small percentage of patients, but those who might be at higher risk for having some clinically relevant consequences.
So any of you using growth factors with CDK4/6 or? No, right? But
it's not necessary. So the incidence of grade 3/4 neutropenia is relatively high, but recovery is very quick. And certainly for ribo, and I believe for palbo, the incidence of neutropenic fevers has been in the single digits. So it's very low, and it's not necessary to use growth factors.
And patients become very predictable over time. You know,
Right.
the patient who takes 9 days to recover instead of 7, you know, we've shown, and I think everybody in personal experience sees that, you know, it's not cumulative, you know, it's not getting worse every cycle, but it's very predictable over time.
Right.
In fact, the recommendation for ribociclib at this point, and that's what we are going to implement in the adjuvant trials, is that once you get to cycle 6, we do not even advocate monitoring blood counts, because by then you have reached the appropriate dose. There is no late emergence of hematologic side effects, and there's no reason for you to continue monitoring.
So even for ribociclib, it's the first week, second week, and fourth week. Is that the way the counts are
First
done?
week, no, we just check day 15,
Day 15.
and again on day 28.
That's the way
For the first 2 cycles.
first two cycles and then first 2 cycles.
That's the package
Right.
insert. Yeah.
Right.
No, right.
Because that's when you're adjusting dose if needed.
Right. Is that the same for abemaclib? I know we don't have FDA approval yet, but that's what you've been doing in trials too, or
Yeah.
checking every 2 weeks?
I'm trying to think. I think it was, in the first 2 cycles it was more intense, and then
Okay.
ultimately it went to monthly.
Okay.
Yeah, so a little bit less myelosuppression with this drug, so
Right.
less of a concern with that. But, and I also have seen a lot of asymptomatic lymphopenia, but again, patients really, you know, it's not clinically significant. And in general, the response and the durable responses, even for folks who have stable disease, has been so much better than what we've seen in the past with endocrine therapy alone, that it's very easy to tolerate this toxicity and generally relatively easy to manage.
Right.
I think oncologists are very comfortable with neutropenia because of how we have to manage it with chemotherapy.
Right.
And it's important, the mechanism, because you bring up chemo, the mechanism of neutropenia with these drugs is very different from what we saw with chemotherapy.
Right.
You know, these are not cytotoxic. They're not, you know, irreversibly damaging bone marrow progenitor cells, but it's more of a cytostatic effect, which allows for the, you know, recovery within a week. And they don't have a very deep nadir, and the length of the nadir is very short. We don't see mucositis and, you know, skin breakdown, things that put patients at risk for neutropenic fever.
So do you recommend, how do you communicate with the patient? You know, it's kind of tough, and you're giving this medicine, the ANC is 700. I don't know how you educate the patient.
Well, it's, you know, a lot of telephone calls,
Right.
and thankfully, you know, we have nurse practitioners who do a lot of the legwork, as I think everybody out there knows. So there's, at least to start with, there are a lot of counts in getting back to a patient, and just many of them are familiar with calling if they get a fever. But then I just can reiterate, the clinical consequence of the neutropenia has not been very great.
Right. Okay, good. I think we'll take a pause, and then we'll go to the next case then.
All right.
Yeah, we're taking a pause, yeah.
Can I get my coffee? Could someone hand?
I thought you wanted
Coffee.
to
Give it
finish.
a shot.
My coffee.
I thought you wanted to finish that.
Yeah.
With endocrine therapy alone is not that great. I mean,
Right.
on this short follow-up of 1 to 2 years, we're doing great because we're in a clinical trial and we're seeing these patients. But if you go to follow-up of adjuvant trials with endocrine therapy, by 5 years, only about 60 to 70% of patients are taking their endocrine therapy.
Right.
There's something
Whether
in
it is
JAMA Oncology just
tamoxifen
this
or
week, I
AI.
would say, right? I got some email. You know,
Right.
you had a paper on Zometa or something, and
right.
then in the same issue or last week's issue.
And if you go to the prevention trials, at the end of 5 years, only 40% of patients
Right.
were taking either tamoxifen or an AI. So compliance is an
Good
issue.
Then I
Because we
think,
talk about patients who complete their
Right.
treatment,
Right.
and we don't talk about the 30, 40, 50% of patients who don't, for whom we don't really have effective therapy.
Right.
so I'll bring this up. So the next two cases are this. One is just talking about side effects of CDK4/6. Should I just do that and then come back and talk about the, or we are okay either way?
I mean, you mean for sequence?
Yeah.
Maybe you want to finish with the CDK stuff
Okay.
before you go.
Okay, so let's just do that.
Yeah, right.
Right, okay. So we
And
are,
these are the last two
Right.
cases.
Yeah.
These are the
Right.
last-
I think so.
Stand by, everybody. I'll give you a countdown. Start camera run. Dr. Abraham, right? Okay, in 5, 4, 3, 2, 1.
so we are still learning how to manage the side effects of CDK4/6 inhibitors because it's a new drug. So let's just look at a patient, a 64-year-old. She's been on letrozole and palbociclib, and day 14, as per the recommendation, a count is checked, and she has an ANC of 740. So what do you recommend in this setting?
Really, you don't need to do anything. This is grade 3 neutropenia. So the most common side effects we're going to see with the CDK4/6 inhibitors that are currently approved are neutropenia and leukopenia. The recommendation when a patient starts their first day of therapy is their ANC should be greater than 1,000. And we know that there's a subset of patients who can drop very quickly. So the day 14 recommendation really came out of some of the Paloma 1 work where the incidence of grade 4 neutropenia, so those are patients with an ANC less than 500, when that occurs, it can occur pretty quickly, and that can be seen at day 14. And if they have grade 4 neutropenia, then you would want to hold until they recover to an ANC of 1,000, then probably dose reduce. But in the setting of grade 3, isolated grade 3 neutropenia, you would just continue as planned. And they'll finish 21 days, they'll take their week off, and on day 1, they should recover to an ANC of 1,000. If not, you delay a little bit. If it's a prolonged delay, then their next cycle you may consider dose reducing.
Okay, so that's really, so ANC less than 500, then you may
Then you
delay.
would react on day 14.
Okay. And as we talked, there's no indication for using growth factors in.
No.
Right. Okay. Is that true for ribociclib to the same guideline?
Pretty much.
Pretty much. Okay.
Very much.
Okay.
And I think it's important to emphasize that this type of leukopenia and neutropenia is not associated to a large extent with infectious complications.
Right. Okay. And abemaclib, I don't know how often we see neutropenia.
Neutropenia is common. It's just grade 3 neutropenia is a little bit, I think still was about a quarter of patients develop grade 3 neutropenia. So
Okay.
it's seen as just less common than palbociclib and ribociclib.
Okay. But you will still manage the same way.
Yeah, I would still manage exactly the same way, and most of it's asymptomatic.
Okay. Antibiotics, do you prescribe prophylactic antibiotic or
No,
you give them a
no,
prescription
yeah,
or no?
no.
You don't that. You're okay. I think we all have to get comfortable with this, living with this neutropenia.
I think we have to look at the patient.
Right.
You know, they
Right.
generally look incredibly good and healthy.
Right.
I think the things that impact them more are diarrhea for abemaclib and then the fatigue. I have had patients have grade 3 fatigue, and I find they declare themselves generally pretty quickly with that, but that's also very responsive to a hold and then a dose reduction.
Good, very good. So then let's just look at, I think oncologists are fairly comfortable in managing neutropenia, as you're saying, even diarrhea, I think we're okay. So what about QT intervals? This is a patient, 55-year-old, otherwise healthy, no history of hypertension or cardiac disease. Now, so day 14, right? I think we are supposed to do an EKG in day 14. The QT interval is prolonged. Again, as an oncologist, I have no clue what to do with the prolonged QT interval.
So we are talking about QT interval of greater than 450 seconds. And what we do in that situation is to interrupt the administration of ribociclib, and we repeat the EKG on day 28 if it is back to baseline. We actually reinstitute ribociclib at the starting dose, and if there's a repeat, then we reduce the dose. If on day 14 the prolongation goes beyond 500, which would be grade 3-4, then we interrupt and we restart one dose level lower. It is important to know that this, like virtually all of the other side effects, occur early during the first few cycles. There are no late occurrence of side effects as is first. There's no cumulative toxicity of any of these effects. So once you figure this out during the first 3-4 cycles, you can continue at the dose that you have arrived at, and it is safe for patients to continue. So interrupt, reintroduce the dose at the same dose if it's grade 1 or 2. You reduce the dose to the next level if it's grade 3 or 4.
So it's baseline EKG, 2 weeks, then again day 28.
Right.
Right. Okay.
And at this point, we are still requesting a repeat EKG on the second cycle, day 14, until we accumulate more information.
So if they have no QT prolongation, then we can stop after.
If you don't have QT prolongation during the first 2 cycles, you don't need to continue monitoring.
Then you can just stop.
Mm-hmm.
Is there any high-risk features? Is it hypertension or cardiac? I don't know if
there has been no clinically relevant consequence to QT prolongation. There have been no changes in rhythm. There have been no changes in blood pressure. There has been no torsade de pointe. So none of the theoretically possible clinical consequences have been observed.
So we don't have to be too nervous about this QT prolongation.
We don't have to be too nervous about it, but until we accumulate more information, I think we need to do our homework and go through this early monitoring.
Is it a class effect or?
No, it is not. We, at least I can speak to the Palbo experience. We actually have a publication submitted that looks across all the paloma studies, and that is not a feature of palbociclib's pharmacokinetics.
And you haven't seen in
I have not seen it with abemaclib.
Okay.
I think where this may become an issue is when someone's on another drug, on Dancitron, ciprofloxacin, something like that. Maybe the primary care doctor will put it in, and it'll bong up on the electronic record. And I guess the right thing to do is an EKG at that point.
Right.
So you do have to be careful about CYP3A inhibitors, because especially the strong ones, and avoid the combination.
Right. So drug interaction is important. That's a good point. Yeah. So, and abemaclib, diarrhea is an issue. So let's talk about a 43-year-old on abemaclib on grade 2 diarrhea, or grade 2 or grade 3 diarrhea.
Right.
Do we stop the drug? Grade 3 diarrhea, do we stop the drug? Or?
Well, I do find that giving a brief hold is tremendously effective. And I also think for patients, diarrhea really has a big impact on quality of life. And if you really look at the CTC AE grades, grade 2 is pretty bothersome. You really couldn't go out of the house, go to work, go shopping. So I think the best thing is to give a brief hold, and I think that it's very helpful when patients can ultimately gain quick control, because you want them to be compliant with the medication. You want them to resume it and continue taking it. And also abemaclib is twice a day. You want them to continue taking it twice a day. So, at least for my patients, I always told them, stop the drug, then call me. Call me right away, but don't keep taking it if there's an issue. And then also when we prescribe it on study, I always told people to have Imodium, in the house so that they could take it. Lots of people needed to take Imodium once a day or make some modifications to their diet, and that sometimes just dietary modifications was enough to control the diarrhea.
So majority of the patients ended up taking Imodium, or?
No, I wouldn't say a majority. 13% had grade 3. I don't know the exact number of grade 2.
Right.
Studies are ongoing looking at Imodium in a prophylactic setting, and so we'll learn more about that.
I think Maura brings up an important point. I think the CTC misclassifies diarrhea. And we've learned this with capecitabine and with neratinib and lapatinib. Grade 2 diarrhea disrupts quality of life as much or more than many other grade 3 toxicities. And patients need to be educated about this. They need to react, and the dose adjustments or the addition of co-medication needs to be implemented, because it is more serious than certainly grade 2 hematologic toxicity or grade 2 something else.
Right. Yeah. So let's look at everolimus. So mucositis is a dose-limiting toxicity. So how do you
Well,
educate
again, here's a case where prophylaxis is important with steroid, particularly dexamethasone mouthwashes, to try to prevent the problem in the first place. And again, if someone develops significantly symptomatic mucositis, I think it's best to interrupt treatment, let them heal up a bit before reinitiating treatment. But I think this is another case where patient education, prophylaxis is key.
And is it the same, like you see it early on, and then as we continue to treat,
yes, usually
patients
early
do better? Right.
It's alcohol-free steroid mouthwash, and it's very effective. What was the name of that study?
The Swish
study, which was just published. Hope Rugo's senior author, or first author on that. That showed the incidence of grade 3 dropped dramatically with the prophylactic.
Right.
So original studies didn't use that. I think
Correct.
we all got
That's
burned by not using that, I think.
And I have patients who had mucositis, even severe mucositis, before this mouthwash appeared, and who tell me that the change is fairly dramatic. And I have patients on everolimus who are now 2, 3, 4 years out and still taking the drug. And the introduction of this mouthwash made a huge difference.
you could still give the 10 milligram, the full dose.
Oh, yes.
Right, right,
Yes.
right.
SWOG has an adjuvant study, 1207, with everolimus for patients with hormone receptor-positive high-risk breast cancer. And when we started, before the introduction of the mouthwash, we ended up with a higher than expected dropout rate on account almost exclusively of mucositis. And that has decreased since the introduction of the mouthwash. So it is important, as Tom mentions, patient education upfront and the introduction of prophylactic mouthwash.
So if you look at all these medicines, a lot of patient education and really, thinking ahead what can happen and telling them, not to panic.
Setting expectations, I
Setting
think, is very important.
expectations. Right. Okay, good, very good.
And we were spoiled in using endocrine therapy alone because we got into the habit of just writing a prescription for tamoxifen or an AI and sending them home for months at a time. You cannot do that with these combinations.
Spoiled, but we always wanted to do better.
Of course. Yes.
It's always a trade-off.
Yes. Yes.
So let's talk about.
And we can get back to the same point after the first 2 to 4 months of these combinations if we do things right up front. We educate the patient, set expectations, make the phone calls, or have our team make the appropriate phone calls, use the co-medication to control symptoms, adjust doses, and then find the right dose on which patients can remain for years. And some of these patients benefit for many months or years of these combined treatments.
So then let's talk about that endocrine treatment. I know oncologists, we think more than 90% of patients take the endocrine treatment which we prescribe. But we know that the data is not true. Do you mind talking more about compliance with endocrine treatment by itself?
So if we go back to the original randomized trials of tamoxifen and aromatase inhibitors in the adjuvant setting, at the end of 5 years, only about 60 to 75% of patients are still taking their medication. The other 25 to 40% have stopped, often without telling their doctors. And this is mostly on account of side effects. And we need to be cognizant of that, ask the right questions, perhaps institute pill counts or some other form of monitoring to make sure that they are taking their medication. They have other options, and sometimes changing from one AI to another AI resolves the problem, or if that doesn't work, going back to tamoxifen can also reduce discontinuation. But patients who don't take their medication automatically have a doubling of their risk of recurrence, because that's what these drugs do, cut recurrence rate by half. And if they don't take it, they don't get that benefit.
So in your practice, how do you enhance or encourage?
Well, I
adherence?
think
Yeah.
one simple point is to ask. If you just assume they're taking their medication, you sometimes are surprised when you ask the patient. And then after that, you have to figure out why and then address that specific issue. So I think that asking, then figuring out what the specific problem is, addressing that problem are the most important things. And patient education, again, to let them know the importance of continuing treatment.
Right. So
And I would point out the trial population is a highly motivated group, and in the real world, we're dealing with less highly motivated people.
I think it's
in aggregate.
It's important to mention that many of our patients, once they complete adjuvant chemotherapy, for instance, if they took that, and they have gone through surgery and radiotherapy and chemotherapy, they think they are done with the important part of their treatment, and they're just taking this little pill that is just for fun, not realizing that that is arguably the most important part of their combined modality treatment. And I think it's important to re-emphasize that. Patients misinterpret, as we discussed at the beginning, being aggressive with chemotherapy, radiation therapy, or something of that sort, as opposed to a little pill.
Right.
And that little pill is a very powerful medication.
Right. So now with these CDK4/6 inhibitors, how do we make sure we can make sure that they're taking the pill? It's a major issue when you move forward, right?
Yeah, and to your point, in a clinical study, we're doing drug accountability and et cetera. Well, for one, they should have some side effects, right? I hate to say it, but neutropenia is a good sign, even if it's low grade with abemaclib, that they're taking their medication. And to be honest, if we're seeing them every month, to the point of being on endocrine therapy alone, and you're not seeing them as frequently, it's easier for a patient to slack off a little bit and, I'm coming to see the doctor, I'll start taking it this week. Whereas you're seeing someone, at least even if it's briefly, for a 1-month follow-up, I think you have a sense of how much they're taking. I think ribociclib, in fact, is coming in a AI ribo pack, right? So
Correct.
since they're dosed together, it's almost like OCPs, oral contraceptions, where there's a dose dispensing pack, and you can keep track. And at the end of the day, it's asking patient.
And I have been burned several times in recent years by not asking. And you need to train your team, your nurse and your mid-level provider, to ask the question and to ask it in several different ways. And you need to ask, because you get different responses from the responses your nurse gets. And sometimes it's useful to check, and electronic health records now give us the ability to check on refills. When was the last time a patient called for a prescription renewal? And it tells you, and you need to follow up on that, because many patients won't tell you because they don't want to give the doctor bad news.
They want to be good patients.
They want to be good patients, and if you don't ask, you don't get.
Okay, good. We'll take a pause, and we will. Anybody wants water? Or
I am avoided saying, well, you don't want Vladimir Putin.
No, you want
Yeah,
I
we'll just do
we'll
it.
You have to.
do this.
Yeah.
I can hold it. I can hold it.
Yeah. Big
Someti-
kid.
I know
That wasn't a
some
joke. That's
patients
serious.
are just
Had a whole cup of coffee.
Have you been
We'll take
taking
us
your
longer if we
estrogen?
take a
I have
break.
to ask you, how many times
you're
did
the
you forget
youngest
to
one
take
this
your
one. You can hold
estrogen
it.
this past week?
Oh, you asked that.
I asked that.
How many times have you forgotten?
Because no, they don't want to tell you, and
We will do this one now.
yeah.
This one.
three.
Yeah, case 3. I know we'll just we'll go for a few more minutes extra. We may do probably.
We didn't do this one already.
We haven't done this.
Okay.
Yeah.
If you get more, then you can kind of pick and choose, right?
Right. We will. This is the extended adjuvant question.
Mm-hmm.
So this is a patient who finished 5 years of AI in your clinic and asking, what should I do? And these are the choices I put. Continue for 5 more years. So let's just go back. She's 2B. So let's just say T2 and 1. And then, so then 5 more years, stop AI, change to different AI, consider breast cancer index, or molecular test. Okay, right, we are ready.
Okay, I think we're about ready. All right, stand by, y'all. Give you a countdown. Okay, we're going 5, 4, 3, 2, 1.
So let's look at another patient. She's 48 years old. She's surgically postmenopausal. History of stage 2B, T2N1, ER/PR positive, HER2 negative breast cancer. She completed 5 years of adjuvant treatment, adjuvant endocrine treatment with anastrozole. And according to the patient, she took the pill. She has some mild joint pain and significant vaginal dryness. So before moving forward, let's just talk about some of the side effects, which joint pain is very common, which we deal with that. But I think vaginal dryness is something which we don't ask too many questions. We don't ask the patients. But the data shows 40 to 60% of the patients have some form of vaginal dryness. How do we manage?
Yeah, and I think not just vaginal dryness. I think there's a loss of libido as well, and pain with intercourse. So if it's painful, women really disengage and don't want to have intercourse. So I think it's really important to address this as sexual health and sexuality is an important component in quality of life. So I think that there are a number of things that we can consider. There are vaginal moisturizers that women can use, And these are products that women can take on a regular basis, aside from lubricants that can be used at the time of intercourse, that can help. And some of them are Replens, Astroglide, Yes, Hyalogen. There's a number of products that are available that helps just keep the vagina moist on more of a regular basis. And also vaginal dryness can also lead to more frequent urinary tract infections, so it's important. And then if some of those products don't work, women might consider intravaginal estrogens, although I use them only after trying other things. And there's also some gynecologists that really have an interest in approaching these problems with women, and I think it's important. Some women get very atrophic, and there's vaginal dilators, so there's a lot of things that can be done. So women should ask their physicians and seek out gynecologists that have an interest in this.
And of course, this is also a problem for patients with ER-negative breast cancer, and just because of menopause. And we still need to ask the same questions from them and offer them the same alternatives. Some of our centers have individuals who are experts in this, and I think it behooves us to refer these patients to them. But if we don't have that availability, I think educating them, making sure that they report these symptoms, and making sure that they use both lubricants and moisturizers, and that they come back to us if that doesn't work, is important, because it is a very destructive symptom, and it really alters quality of life and relationships.
So if the lubricants don't work, have you prescribed vaginal estrogen cream, or how do you discuss that with your patient?
I try everything else before I feel comfortable about prescribing vaginal estrogens to women with ER or hormone receptor negative breast cancer. The issue is in these patients with hormone receptor positive breast cancer, in whom we are considering, of course, long-term endocrine therapy. And with tamoxifen, it's not as much of an issue, because tamoxifen should take care of blocking estrogenic effect wherever that comes from. But there's a small amount of absorption even from vaginal estrogen, so you need to have the discussion with your patient that there are no guarantees. And while in the presence of very severe gynecologic symptoms, this is perhaps worth considering, and I do it occasionally. It is not something that comes with an ironclad guarantee that there is not going to be estrogenic absorption. And we don't know exactly how much or how little it takes to, have some clinical consequences.
Right. So this patient, she's really motivated. She's willing to do anything, and she's sitting in your clinic now 5 years into this treatment. So her question is, should I continue AI and beyond 5 years? So some of the options, one is, and we've been talking about continuing beyond 5 years. That's one option, or stop, or change to different, or consider some testing. I don't know, how do you approach in your clinical practice?
Well, I would say, I think one thing in your presentation kind of was very similar to or kind of echoed what I see in clinic, is the patient was willing to do anything. I found a lot of these patients kind of self-select. There are a group of patients who say, 5 years, that's the end for me. They can't wait for that finish line. And it's independent of their risk, almost. And there are other patients, sometimes independent of their risk, who will do anything to continue. So I've just found a lot of these patients kind of self-select. And a lot of it is educating people that the benefit is minor, or someone has a higher risk disease, that it turn of proportional risk reduction is low, but in her case it may be worth considering. So I think in this case I would probably continue the AI. I guess you could talk about one of these molecular tests, but I think that's more useful when one of you is in equipoise.
When the patient is questioning the benefit.
Yes, where you and the patient are unsure, or in equipoise, are debating.
Right. How do you approach?
Well, I agree that, and also when a patient is unsure, I do look at their risk of recurrence. We know the data suggests that we can improve disease-free survival, but that one of the events is contralateral breast cancer, and that's included in the DFS endpoint. And really much of the benefit is in reducing the risk of a contralateral breast cancer, a new primary. So for women who opted a surgical approach, bilateral mastectomy, where they don't have another breast at risk, I'm less likely to be dogmatic about need. However, for my lymph node positive patients, I do think that risk of recurrence is spread out over many years, and that even 10, 15, 20 years from now, they do have measurable risk. I think one of the most important presentations that I saw at ASCO in 2016 was from Pan et al. Colleagues who looked at the overview analysis and rates of recurrence at 20 years. And for women who had lymph node positive disease, it was much higher than I expected. So I try to educate women about their potential risk and that it can be many years from now. And for my lymph node positive high-risk patients, I encourage it if they've been tolerating their AI up to that point. That's the other thing, is that if you've gotten a patient to 5 years, they're generally doing well and are often willing to consider more. Whereas the patient that stopped the AI at 2 or 3 years, it's a non-starter.
Right.
I think there may be too this carryover effect where the effect of endocrine treatment carries over for years after its discontinuation, implies that we're going to have to wait a long time before we really get mature data on these trials.
So have you used any of the molecular markers in deciding beyond 5 years?
Not in this setting. I think it's a very interesting though, but by continuing it longer, are we curing patients, or are we just suppressing disease that is there, right? And I think the issue as far as overall survival, I mean, this patient is younger, but if for someone who's older and they're not at that as long of risk, or they recur metastatically and then they just get treated again, right? I mean, if they have a disease-free interval of several years, they can go back on an AI at that time, given they're not curable. But it's an interesting thing to think about.
So B42 hasn't really stopped, kind of said, okay, I should stop at 5 years. So you're kind of saying still the question is open and we should continue to discuss with the patient. Is that the way you're approaching?
So I knew the answer to this question 2 years ago, but I no longer do. When the Atlas Atom trial came out, and then the Canadian MA17, and then a couple of the other trials that showed that longer is better than shorter, I was pretty much convinced. And then my conviction has been shaken in recent years, both at ESMO last year and ASCO this year. So I no longer know. I am starting to use the breast cancer index and Prosigna to try to get an idea of continued risk, whether there is a real ability to identify these patients. But of course, those assays don't really tell you, despite their claims, whether prolonged endocrine therapy will actually work in that group of patients who the tests suggest need it. So we are going to have more information about prolonged endocrine therapy over the next several years. I tend to insist more on patients at high risk, those with multiple lymph nodes or larger tumors, or with higher risk at baseline, and much less so in patients at lower risk, node negative or smaller tumors or lower recurrence score or something like that. But I don't know that that is the right answer, because these patients do indeed have a much more chronic course. It impresses me that the triple-negative breast cancer, once you get beyond the first 5 years, those patients are probably cured. These patients, I'm not sure they are ever cured. And if they live long enough, the risk continues to increase. So this is a very important question, and it's a moving target at this point.
And just to tie into the rest of the discussion, now there's several adjuvant studies with CDK inhibitors, right? And those won't read out for some time, but the field is changing.
Mm-hmm. So all those, Pallas and Monarch E, I think.
Early.
And then ribociclib, there is.
We have 2 adjuvant trials with ribo.
Right, 2 adjuvant trials. And post-neoadjuvant trial with B54.
Right,
And right. Good, very good. I think we can conclude. So, yeah, we can pause, yeah. So, right, anything else? It's like I'm learning a lot. I feel like.
This isn't even for the internet. This is just for you, right?
Just
A
for
whole
me.
falsehood.
I'll pause it then.
Go home and put it in the DVD player.
Okay. So just we are done. So just say
Close
thank you
it.
all and is
You want to thank your guests and,
yeah.
okay, yeah.
Yeah.
Mhm. Yeah.
Don't you have some text there? Like, thank you for joining us? No?
I don't think there's any.
Just make it
text.
up.
Just make it up. Yeah. If you want, you can say that. You look bad.
Brought to you by.
It's a fail.
So you want Dr. Abraham?
And now a word from our sponsor.
When you go into a Viagra. Oh, no, that wouldn't be fair and balanced.
We need a Viagra pill. There is one, flibanserin.
That's right.
That's right.
We need
Yeah.
to study it.
Okay, if you're ready.
Right.
All right, stand by, everybody. In 5, 4, 3, 2, 1.
Thank you all for joining in this really informative section, and I really thank our faculty members for enlightening all of us.
Good.
Nice job.
It's a wrap.
The audience will be in a second.